Thank you very much. Hello, everyone. I've been talking about coverage for the last 12 months a lot. If you've met me somewhere, I think I was the guy who was putting his hand up and just saying things like, coverage, SQUEAC, coverage, all the time. At some point, I suggested everyone was introducing to me like, oh, you are the coverage guy, or you are the SQUEAC boy. And I was saying, well, not actually, but I feel like I have managed to pass a message. And when I was preparing this presentation, I was thinking, okay, I'm not going to talk a lot about coverage this time, because I've been talking already a lot. I was listening to the people who has been talking before me today, and I was just writing down, counting how many times the word coverage has been said. Emily just said 9 times the word coverage in her introduction, which in 10 minutes was quite well. It was just 1 coverage per minute. It was very good. I was a little bit disappointed with Saul, but he had to summarize many things. I started to count the times that Mark said coverage. Before his first slide, he said it 12 times. And I just decided not to continue counting, because otherwise I will run out of post-its for everyone. So I titled this presentation The Usual Suspects. And I'm going to talk about many things that all of the other people before me have already talked. Yesterday, since the first day, till Mark right now. But I'm going to try to present them with new data, why these usual suspects are so important, to give you more reasons for that from a different perspective. At the same time, I'm going to build a little bit on what Mark has just said and continue what he said about the coverage monitoring network. And finally, I'm going to try to address these things. I think we have a lot of data around coverage, but I think we need to take that a way further. Oh, can you see the map very well? Yeah, because you're quite familiar with the map of the world. The quality is not very clear in that. In the computer is much nicer. But that's a map of the world where the coverage monitoring network has been doing coverage assessment in the last 12 months. We started supporting coverage assessments in September 2012. And since then, 12 months later, we have support coverage assessments in 24 countries, and we've done around 57 coverage assessments. So that map is mainly where we've been in these last 12 months, but it's also the map that reflects demand on coverage. So I think that map is exactly where people are demanding doing coverage assessments. There are some countries that are not there. Malawi is not there, for example, and the coverage monitoring network is not been in Malawi. That doesn't mean that we have not done coverage assessments in Malawi. A lot of people have been doing coverage assessment through all the methods. But that kind of reflects, one, where was the need of doing coverage assessment and where we have gone. One thing I have to say about the coverage monitoring network is whenever someone has come to ask us for support for coverage assessment, our answer has been always yes. Always. So there's been not any supply barriers on giving coverage assessment. Our answer was yes. Where, how can we do it? So that is exactly where the demand on coverage was. And as you can see, you know why the demand was there. But countries as Kenya, Chad, Niger, Burkina Faso are more in red. We've been there more than 9 times in some countries. Countries as Haiti, we've only been there one time. And we were able to do this, and I know this is going to surprise you a lot, but because we were a partnership. Actually, our partnership is the most flexible partnership I have ever met. I've done partnership at national level for doing national surveys, and sometimes partnerships are just quite the opposite for flexible. It's like you need to develop some activities, and you have to engage to the rules and regulations, not only for one partner, but for 5 partners, and that gets impossible. Here we had I don't know if you can see the logos from the back in the bottom line, but that were our partners. And the good thing about this partnership is whenever we face a problem, from getting a visa from South Sudan and one partner could not do it, I took the phone and I phoned the other partner and I told them, I cannot get a flight in that WFP flight. Can you get me that? And they say yes. And in 24 hours I had that answer. When I needed to do a SLEEK instead of a SQUEAC and I don't have the capacity, I could phone Valid, and they were also, yes, don't worry, we'll find a way around it. When we needed to go to a Portuguese-speaking country, we find someone who spoke Portuguese. When we needed to change the budget lines, we found our donors, and there was OFDA and ECHO were always at the other side to say, no problem. The important was doing the activities. And I really want to thank all the people that was behind those assessments. The data I'm going to present here are just data from 57 of these coverage assessments. So it's clearly most of the data is coming for those countries that are more in red. But it clearly represents a little bit what is happening everywhere. Sorry, as you've seen also, there is a lack of data on Southeast Asia. Again, it's not because we could not go there, but it's probably because there is not enough demand on coverage there. I think one of the duties also for the next time is to create more demand on coverage assessment in Southeast Asia. That's, I don't know again if you can see it very well, but I think you can. That's the principal barriers that we have found in 48 of those 57 coverage assessments. And as you can see, the first two main barriers are lack of awareness about malnutrition and lack of awareness about the program, who appear up to in 35 on 48 of those coverage assessments. So up to 70% of the coverage assessment we've done, lack of awareness about malnutrition and lack of awareness about the program were there. In which countries? You can see them, but it was mainly in those countries where we've been most, in Chad, Kenya, Burkina Faso, Niger, that appear many times. In those countries we've been less times. It doesn't appear so often, but it appears there. It's always there. The third one is high opportunity cost. It's always there also. In more than 50% of the coverage assessment we've done, high opportunity cost has been an issue. Distance, in around 50% of those coverage assessments we've done, has been an issue. RUTF stock break, it's been also an issue. Poor delivery of service, unsuitable treatment interface, they have all appeared. Unsuitable treatment interface sometimes refer to the problems we have between SAM and MAM admission criteria and how they can, we've talked a lot about how important early admissions are, for example, and sometimes we have forgotten that when we do a coverage assessment on SAM, we have not the control on what's happening on MAM, and that has a strong impact on what we are doing on SAM. And that's just reflecting that in those kind of barriers. You don't have this graph on this nice torch. The other ones you have them, but not this one because it can get a little bit tricky to interpret. It's a little bit different. What I've done here is I've chosen the main when those assessments who have that main barrier for it, and I see what was the average coverage rate that we get when that main barrier was present. So, for example, the bottom one, which is RUTF stock breaks, for those coverage assessments that identify RUTF stock break as their main barrier, what was the average coverage that we get in those coverage assessments? Okay, it doesn't mean that if you had that barrier, you will get that coverage rate. It means that on those coverage assessment that barrier was identified as the main one, that was the average coverage assessment we got. And as you see, it shows something quite interesting. I think it's quite a link with what Mark was saying about the availability of service, the demand on the service, etc., all this Tanahashi model that was built upside down now here, which is if we have our UTF stock breaks as the main barrier, if we don't have our UTF, it's quite clear that we cannot have a CMN program. And it's quite difficult that we are going to get a high coverage rate. But once we have our UTF available, there are other barriers that appear that we've mentioned. Lack of awareness about program, lack of awareness about malnutrition, and all those programs that have those barriers, in average, doesn't perform much better than 30%. When you remove those barriers, new barriers start to appear. And I think that's also a little bit the magic of what we've been doing with SQUEAC. Like we were working on some barriers, and when we try to remove those barriers, we realize, oh, coverage is still low because new barriers appear. The second part of the presentation is how are these barriers being addressed. One thing we have discovered is when we arrive to a country and the first thing we do is trying to talk with the program nutrition manager or the person who is effectively responsible of the program on the field. And we ask them, can you tell us what do you think are the main barriers here? And we write them down in a list. Then we do our coverage assessment. We go back to him and we told him, oh, those are the barriers that we have found. And they're exactly the same as the one that this person told us at the beginning. So if he mentioned people don't know about what is malnutrition and distance, the things that we will find is lack of awareness about malnutrition and distance. So the first question they often ask is, okay, very nice, but that's what I told you 3 weeks ago. So I hope you had a good time here during these 3 weeks, but maybe you could have saved that time. That's the first thing that we often ask. But I think SQUEAC assessments are much more important than just getting a number, and much more important than just getting the barriers. When we do coverage assessments, we often work quite close with the teams, and we help them to clarify really how all these barriers interact, how all these barriers are impacting the program. It was a little bit the graph that Mark was showing at the end. So we try to clarify all the interaction that there is, and how if you really address one barrier, you can improve coverage. And it's really kind of a very interesting tool for them to use, because it helps them to explain and to advocate for the needs that they really have. There is one thing that we need to change, and it's that perception that if we build a program, they will come. I think most times we put a lot of efforts on building the program, getting the funds for the program, and we hope they come. We've started doing coverage assessments, for example, in programs that were quite new, just for 5-6 months. We got a coverage rate of maybe 15, 17%, 20%, and sometimes we told them, don't worry, your program is just starting now. We will come back next year, and people will know your program, your coverage is going to be 50%. So that bad result now is just because you are opening doors right now. So don't worry. We came a year later, we made our coverage assessment again, and we said, well, actually your coverage is again 15%. So if you do nothing, coverage doesn't improve. Coverage remains the same. You really need to engage people to come. So more detailed and practical guidance needs to be done, and we need to work really close with programs to start integrating these measures. I think what the coverage monitoring network has been done is being great, but we need to start now saying, okay, that's your coverage. We need to find a way where we can support you to commit to address those barriers. It's very clear to us also that each service requires very specific measures, but as you saw in the first graph, there is 2 main areas which appear everywhere, in 70% in the coverage assessments everywhere in the world. And those are improving awareness and reducing opportunity cost. And I was just to focus a little bit on those 2. So, and I think it's some of the main issues that have been talked since the first talk. It was Steve Collins who opened these talks, and he mentioned already some of the issues that I'm going to say here. But I want to go over them again, because I really think that they are the way to move forward. So improving awareness, what's happening? I think we are not dealing with it in the right way. We often see improving awareness activities as a one-off activities. I think Andre Brienne was also talking about we need to do MUAC screening monthly. It's not like I just got a small amount of funding for doing one MUAC screening once. No, if we don't really incorporate that activities into the regular monitoring part of every program, it's going to be really difficult, and we can engage and improve coverage. The improved awareness activities are always activities for which resources are always limited. Anything we want to do is we have a small amount of money. I know this is things that we've been saying about funding programs, that we have only really a small short funds and no long funds, and it really work to do, but it really applies when it comes to these issues, that we have only money for resource are very limited. And when we think about other social, other public health interventions, as I think we were discussing this also yesterday in the working groups, in many working groups, how we can learn from other public health interventions, such as HIV or TB, they had a lot of funding and activities for doing that we can call social marketing, and they have learned very well that's what they need to do before to reach all the communities. And I think that was in the core of CMM at the beginning, but at some point we've missed that way. What needs to be done? We need to recognize that. And I think I was talking yesterday from someone from Namibia, if I'm not mistaken, and they were saying, yes, of course, we need to integrate CMM into health systems. That's a fundamental issue that we need to do. But when doing that, we don't need to forget that we need to engage with communities more. And that's a role exactly when NGOs can potentially play a key role on it, because we know, and it happens it happens in health systems everywhere, even in the UK or in the US lately, that's the thing that we often leave aside. And that's where I think NGOs, we can play a key role to support health systems into address these problems. I'm running out of time, I know. The other thing I wanted to mention is reduced opportunity cost. We've talked a lot, and it's something that's happening a lot. I was working in nutrition. When I started working in nutrition, I had no idea what CMN was. I was working in a small clinic, and then I moved into ACF. They told me what CMN was, and I said, oh, CMN is amazing. And I started to understand all the problems, why most of the costs remain prohibited for many people to address the service. And it's true that the service delivery model has changed little. Someone was saying also the other day that we are a little bit conservative about this thing, in this world about nutrition, and I think it's completely true. Reduced opportunity cost is quite mixed with seasonality, stigma, security, and more other issues. So we need to address this problem again, and we need to be very flexible and versatile to adapt the activities and some of the ideas that you can do to address all these barriers that we've talked. I've run out of time, but the conclusions are just what I've been talking a lot. So thank you very much. I hope you enjoy the rest of the day.